Awesome. Well, good afternoon, everyone. How's everyone doing? First day of the conference. Thank you all for coming today and being open to learning about intersex care and how to make your practice, your clinics more intersex inclusive. My name is Adrienne Marks. I am a nurse practitioner and also a health educator at Lurie Children's Hospital. My colleague,
Hi everyone, my name is Adam Davies. I use they, them pronouns. I also work at Lurie Children's Hospital as a health educator. I work in our clinic with patients who have differences of sex development, and we're gonna talk more about that. Outside of that, I run a HIV prevention and sex education program for high school students, and I serve on the board of directors for Interconnect, which is a nationwide intersex support organization. I did also want to say, so I have an intersex condition. I have a variation in sex traits. I'm going to talk about it a little bit, and Adrienne is also a person who has one of the conditions we're going to talk about, so we're kind of weaving in our unique experience with that as well.
Awesome. All right, oh, there we go. It's fun being in this big room. It's like, woo. Just a disclosure, nothing to disclose for myself or Adam. We have three main objectives today. First off, we hope everyone here comes away with gaining just a foundational understanding of what intersex or DSD variations are. As you noticed already, there can be a lot of different terminology that can be interchangeable. For example, I already said DSD, which stands for differences in sex development. We'll talk a little bit later on about other potential terms that may be used and how to use them appropriately. The other thing we wanted to just highlight as well is that Adam and I are not physicians specifically trained in endocrinology or other specialties within the intersex community. So if there is a specific niche medical question, we can help you find that answer. We may not know it right away. Our second objective is that we hope everyone here comes away with an understanding of the importance to incorporate the voice of the intersex community and also how to do that and how that can really improve patient outcomes. And third, we will go over some really tangible, concrete ways that you can bring back to your clinic to hopefully make it more intersex inclusive.
I'm going to start just by going through a definition, and we're going to talk through kind of what some of the most common intersex variations look like. If you hear the language that I am using and you go, Adam, I'm a doctor, please use more advanced language. I'd like you to know not only am I modeling or I'm using language that everyone can understand, I'm also trying to model how I would talk about these topics with a community member in my organization. Right, so I'm going to use language that I would use for you all, and I would also use for somebody who has a low level of medical knowledge. We'll start with the definition, right? So intersex is an umbrella term. It's used to describe a wide variety of variations. I always laugh when I say that. You're going to hear me say variety like 800 times today. But we're talking about variations in sex characteristics. Things like chromosomes, gonads, genitals, and hormones, and I'm going to go through kind of each of those with some specific examples. It's really important to know that these characteristics are congenital. They're from birth, so if somebody were to get something changed as a part of a transition process or as a part of a medical procedure, that is not considered intersex. For people to be intersex, these are traits that they are born with specifically. And for people who are intersex, these traits don't align with our socially and medically defined boxes of male and female. But what we're gonna see is there's a lot of things that don't kind of fit neatly into those categories. I also like to say, so although intersex variations are congenital, there's usually 3 different times that we see people kind of find out that they're intersex. The first of which is at birth. if somebody has a difference in genitalia that's clinically apparent. The second of which is puberty. That's the one that I feel like maybe is most relevant for adolescent medicine providers. If you're seeing a patient who is not going through puberty or they're going through a puberty that looks different. And then the third time is during like fertility care. And we're going to talk about it a little bit more. So this is just some examples of different chromosomal variations that we work with. So you can see here on the left, XY is what we would generally assign male at birth. XX is generally assigned female at birth. But there are a number of different ways that chromosomes can look. The one I like to point out here is Klinefelter syndrome, mostly because we have started to be able to flag Klinefelter syndrome on prenatal screening now. And so for people who have that, we're able to kind of identify that at an earlier age. Which can then help us throughout their lifetime get them access to different resources. For Klinefelter and Turner syndrome, those can come with things like learning disabilities, ADHD, and so the earlier we can identify those, the sooner we can help people. Reproductive organs as well. I like to talk about gonads. This is my favorite one. I have a gonadal variation. I'm going to talk about it later on. But we know that gonads usually develop into ovaries or testicles. But for some people, we see things that are a little bit different. That could include things like ovotestes. Somebody may have like a testicle on the left side and an ovotesty on the right side. And we also see things like streak gonads, which is where the gonadal tissue does not develop into an ovary or a testicle. In the community, this is one of the spaces where I maybe start to see people who don't have a great understanding of what body parts they have. I think sometimes people have a lot of confusion over like what gonads they do or don't have. And so that's an area to kind of help folks. I put this up here. I hope this looks familiar from your like medical school classes. I don't know. I start medical school in the fall, so if it doesn't look familiar, I guess I'll learn and then I'll upgrade it in the fall. But this is just a graph of how like genitals develop essentially. So you can see here everything starts from the same place. It's undifferentiated genital tissue. When I explain this to community members, I try to make it really clear that that's the case. And then somebody would either develop a penis in the presence of androgens or a clitoris and a vagina in the present or without androgens. The reason why I do that is because for a lot of community members, they think that they have both a fully formed penis and a fully formed vagina. I found that a lot, and so I like to kind of let people know, hey, actually, like, that's not possible, but you might have something somewhere down the line. So our differences in gonads specifically, or hormones that are present when genitals are developing, is what can lead to these genital differences. And these are the ones that, like, if you're like out on the street and you ask somebody what intersex is, which I don't recommend doing, this is the one that people always fixate on, right? They want to know all about genitals. Kids will be like, oh, like somebody has a penis and a vagina. And I'm like, close, you're trying, right? But genitals are not just constricted to a penis and a vagina. I had to remove my diagram of the Prater scale off of this because it was copyright. So if you want to Google the Prater scale, that'll help you get a good kind of idea of what differences in genitalia can look like as well. But essentially what we see is kind of along a spectrum of anything from a fully formed penis to kind of in the middle, maybe somebody has an enlarged clitoris and maybe they have some rutigation in their labioscrotal folds and things like that, all the way to like a fully formed vagina on the other end of the scale. Other examples of genital variations include things like hypospadias. That's where the urethra is not at the tip of the penis. Perhaps it's somewhere nearby or it's in the shaft of the penis. I included this one. There's some controversy about whether or not hypospadias is a part of the intersex community. I include it because from a community perspective, I have friends, there are people in my group who have hypospadias, and so I include them in the conversation. MRKH is also one that you probably flag if you're working with teenagers. That's the absence of a vagina or a shallow vagina. A lot of people with MRKH are gonna find out they have that during puberty. They're gonna go to the doctor because they're not getting their period, and that's when they're gonna kind of figure out that that vagina is absent. I talked about enlarged clitorises or small penises, and then the other genital difference that we kind of talk about or we see in clinic is something called a urogenital sinus. And so that is where the bladder and the vagina exit the body through like one hole, essentially. So the urethra and the vaginal canal exit through like one hole instead of two. and hormones as well. So like I said, right, like those hormones when that baby is developing plays a huge role in the development of internal and external genitalia. The two you're gonna hear us talk about a lot, and I have some scenarios later on, so if you don't have friends, you're gonna make them later, because you're gonna have to sit next to some other people to talk through them, but CAH and AIS are gonna come up in my scenarios a lot. Essentially, like the hormones when that baby is developing play a role in what those genitals end up looking like. And the two really common examples I like to share are congenital adrenal hyperplasia. It's actually an adrenal gland condition, but because the adrenal gland is unable to produce cortisol and aldosterone, cortisol being like the stress hormone, the body sends extra signals to the adrenal gland, and that causes the overproduction of testosterone. My slides are a little out of date. That should say that it's clinically apparent in people with XX chromosomes. So in people with XY chromosomes, they are also overproducing testosterone, but you're not seeing changes in genitalia like you do with people with XX chromosomes. And then AIS is another really common one. For AIS, people are unable to respond to testosterone, and so their bodies convert it to estrogen. This can happen completely in complete androgen insensitivity syndrome. In that case, we're seeing people who have testicles, but they also have a vagina, and they usually develop like what we would consider like female secondary sex characteristics, and then it can happen on a spectrum. So somebody may have partial androgen insensitivity, and they might end up with some genitalia somewhere in between. The reason why I like to point this one out, especially for this crowd, I think, is because for people who have AIS, if they are also trans, their transition can look a little bit different, right? If your body is unable to respond to testosterone and you would like to go on testosterone to transition, that might not be an option for you. And so you might have to work with a doctor or a healthcare provider to kind of brainstorm, right? Like, what are things I can do to transition to make myself feel more comfortable that don't involve going on testosterone? And I always like to point out that people's bodies make estrogen and testosterone at different levels. Like, that definitely is the case for people who are intersex, but also like everybody's bodies are just like very different. And I'm gonna pass it to Adrian.
Awesome, thanks, Adam. So kind of after going over just a medical foundation of what intersex can be and what it can look like, we wanted to now go into a little bit more about the history in terms of how that community may intersect with the medical community as well. As mentioned at the beginning, there's a lot of interchangeable terminology, vocab that can be used within this community. On the right side of the slide are terms that are generally not used or appropriate anymore, with the caveat of if the person prefers to use that terminology, then it's okay. On the left, we have terms that are more widely accepted and generally okay to use. We've talked about differences of sex development. Nowadays, we're hearing a lot of people prefer variations in sex development. Another important term to just understand is endosex, which is someone who basically is not intersex or does not have any variations of sex development. I think the big thing to take away with vocabulary is just asking the person what they prefer to use. The umbrella of intersex, there are a lot of different conditions, a lot of different people, and some people often just prefer to use the name of their condition. For example, I have congenital adrenal hyperplasia, or CAH, and the terms up here really don't feel right to me, and I prefer to use just the word of my condition, CAH. Awesome. We're gonna tackle this slide.
Yes. Okay, so these are just some common misconceptions that we hear, both within and outside of the intersex community. The first one is this idea that intersex people have all or both parts, or are both sexes. I think I kind of debunked that already. I'll just say it again, right? Like, nobody has a fully formed penis or a fully formed vagina. I think that type of education is really important to me, because when I see people outside of the intersex community, a lot of times the reason why they're using language like that, or the reason why you see it in movies, is it's kind of pushing intersex to the extreme, right? And that's something that is kind of increasing stigma, or like this idea that being intersex is like not normal. Within the community, it just points to that lack of medical education that people may have about their bodies.
And then another common misconception is that all intersex people have some type of genital variation or they've all had surgery. As Adam has gone over, that these variations can be many different things. So it could involve chromosomes, hormones, and maybe not involving genitalia whatsoever. I think in the last few years, there's been a lot of discussion around intersex and surgeries, which is very important to talk about. But there is a whole other side to this community that does not involve that surgery discussion.
The next common one we hear is that being intersex is very rare. And I will say that there's kind of a difference in the ways that different people define the word intersex. So in the medical community, there is kind of like one group of people who would define the word intersex as being strictly like differences in genitalia. That's about 1 in 2,000. Within the intersex community, a lot of folks like to have a little bit more of a more inclusive kind of definition, or maybe just like a definition that includes more conditions, including things like those chromosomal and hormonal variations. And that's when we start to get into the like 1 in 200. So right around 2% of people could be considered intersex.
And then another one, as you can see, is thinking that intersex is only within the pediatric community. It's only affecting kids or babies or adolescents. As mentioned, this is a congenital condition that carries with someone throughout their whole livelihood and requires follow-up and health care through their entire life.
And then I'll tackle the last two. So this first one, all intersex people are LGBTQ. So there's a few parts to this. The first of which is that not all intersex people would identify as LGBTQ. There are intersex people who are also LGBTQ. And the second part to that is that I always see this with like organizations who will say LGBTQ and then they'll just like tack on the IA, right? And then if you're like, oh, like, do your grants go towards like intersex programs? Do you have any programming for intersex people? Do you offer any resources? And they're like, I don't know what an intersex person is. And I'm like, okay. So maybe like sometimes I think there can be a harm to including intersex people in the LGBTQ community because I think they get included as an afterthought, and that leads to kind of a lack of access to like resources and things like that. The second one is that all intersex people are trans, or all transgender people are intersex. That first part, some intersex people are trans if their sex assigned at birth, or sometimes we call it their sex of rearing, is different from their gender identity. My sex assigned at birth was female. My gender identity is non-binary, so I identify as transgender. But I have plenty of friends whose sex assigned at birth is female, and they're like, yeah, I identify as a woman, and so they would not be considered transgender. On the flip side, and what I think I have seen even more and more as kind of the debate around trans people ramps up, is this idea that trans people are all intersex, or this idea of using intersex as like a card or like a talking point in a conversation about trans individuals. And so there's like two parts to that. I'm gonna get on my soapbox for 30 seconds, and then I'm gonna get off my soapbox. The first of which, right, is that I think a lot of people will use intersex as a talking point, and then they don't do anything to help the intersex community, right? Intersex people are not here for you to prove like that transness is valid. Transness is valid without the necessity of using intersex people's identities to legitimize it. The second of which is that I see a lot of trans people, and especially younger trans people, so if you ever see this in clinic, they will claim to have an intersex identity. So they will go, oh, like my brain is female and my body is male, so I am intersex, or something like that. And the reason why that is kind of an issue, and that's something where I would ask you to be like, oh, actually, like, intersex people are like a separate kind of community. They have their own kind of difficulties. You have to have kind of one of these specific medical conditions to be intersex, because otherwise, like, those trans people are kind of like taking resources and taking identity from individuals who are intersex. So I do see that a fair amount as well. I'm off my soapbox. I'm going to talk a little bit about discrimination and what I'm calling like interphobia, which is very similar to what we would call transphobia, which is discrimination against people on the basis of their intersex identity. That includes anything from microaggressions. I just like to use the example of like jokes about like penis size falls into this category, right? If you're dropping a joke about someone's penis size, you don't know who else might be in the room. And a lot of times, folks who have small penises are also people who have intersex conditions. And we see systemic discrimination as well. I like to like keep on top of the research that's out there about it. And the article that I was kind of reading most recently was from 2020. And what they did is they looked at the experiences of people who were LGBTQ who were not intersex and people who were LGBTQ who were. And what they found was significantly higher rates of unemployment, significantly higher rates of not accessing medical care, significantly higher rates of feeling like they couldn't advocate for their family, of leaving jobs, of education discrimination, just significantly higher rates of discrimination. I think there's a couple of reasons for that. I think the main one that I always think about is that if somebody has secondary sex characteristics, visible characteristics that look different or might kind of be like visible to people, that could be a reason why that discrimination occurs. And then I like to think about intersectionality as well. The example that I always use is if someone is both Black and intersex. So we know that for Black patients specifically, doctors are sometimes less likely to listen to them or less likely to believe that they experience pain. For intersex communities specifically, we're going to talk about it more, but there's a significantly higher need to explain your condition and your medical needs to a healthcare provider. And so if we think about the way that those two come together, I can imagine a scenario where somebody is needing to explain their specific health condition and their struggles, and they're also not being listened to or not validated because of the intersection of those two identities. Oh, and this is mine too. Oh no, and the next one's mine too. Okay, anyways, I just like to put this in here too because I think, as Adrian said, there's like a lot of conversation around the intersex community. A lot of the conversation around the intersex community really centers around like surgery and when to do surgery and how to do surgery. And I like to shift the conversation away from that towards like, what does my ideal world look like? And what I see play out in my friends and what I see play out in clinic and what I see play out all the time is that our kind of really rigid gender and sex norms are causing a significant amount of shame and stigma for intersex young people, intersex adolescents, and intersex young adults, right? Our idea that there are two boxes, right, and there are specific ways for each of those boxes to be is something that I see really play out in harm. And so the message that I always like to share is A, right, like intersex people are normal and valid variations of humans, but B, like it is our responsibility as medical professionals to kind of help change society in a way that my intersex young people don't have to worry about showing up to school and facing stigma and discrimination. Ooh. And we're going to talk about medical experiences too a little bit. And so when we talk about specific medical experiences for the intersex community, what they found is that compared to the general population, intersex individuals are more likely to report unfavorable experiences accessing healthcare, including things like poor communication. They don't feel like their doctors are explaining things to them correctly. They don't feel like their doctors are kind of using the correct language. We see a large amount of dissatisfaction with care, and also intersex individuals feel like their preferences and choices for medical care are not being heard by medical professionals. And I think a portion of this comes back to language as well. There's a study a couple of years ago that came out that showed that if somebody uses language that an intersex person doesn't like use or doesn't resonate with them, they're significantly less likely to come back to that person's clinic ever again, right? Once you kind of are using something that that person doesn't like, they're not going to come and see you anymore. Intersex individuals may avoid disclosing. This is where I like to joke about the ancient intersex art of lying about your period, which everybody does. It's like a thing. I started going into community spaces and I was like, oh, so y'all are all lying about this too because it's easier. And essentially what this is, right, is like, as an intersex person and as my friends, we're going to take stock as to whether or not it's important for you to know about my intersex variation, and if I don't think it's going to impact the care that you give me, I'm not going to tell you. That could include things like lying about when I last got my period, so you don't ask me 300 questions about my condition, and I have to tell you about the fact that I don't get periods anymore, et cetera, blah, blah, blah. Right, like a lot of people are not going to do that. And in fact, one of the kind of pieces of advice that gets passed from person to person in the intersex community is to lie about your period, is to kind of say this so that you can get past that barrier and you can access medical care. Individuals often feel like they must educate providers. So I run a session at the support group that I'm a part of on how to access intersex affirming care for adults who are intersex. And one of the things that became really apparent to me really early on is that a lot of intersex individuals are working with physicians who maybe don't know a lot about treating intersex patients. And I remember just one friend who was like, yeah, I have like a 20-page book, right? I have everything about my medical history, my condition, the websites to go to, like who to talk to, and I hand that to every doctor I see. Because otherwise I know that I'm not going to get kind of the level of medical care that I want to get. And then we do know that access to psychological services can improve a person's satisfaction with healthcare. We're gonna say this also like a number of times. You're gonna hear it a lot because I think it's really important, right? Is that intersex individuals deserve access to psychological support and psychological support that is able to be affirming of them and who they are.
Thanks, Adam. So kind of building on that, just thinking about these barriers that intersex individuals may have to go through navigating the medical community. There are also considerations regarding specific healthcare needs. We want to just put up a list of various examples of what this could be in terms of specific gynecology services, prevention of osteoporosis. We will unfortunately go into individually what each condition may need, because that could take a while, but really highlighting that each condition, each person is their own individual, and they may have different needs. And just being mindful of asking them what those needs may be. And we kind of already started to talk about this, but we really wanted to highlight that there's really a huge gap when it comes to adult care for intersex individuals. As we've talked about, this really is kind of siloed into the pediatric setting, understandably, because it's often diagnosed at birth or in puberty, adolescence timeframe. And because of that, a lot of the specialists in this area are pediatricians or working in that pediatric population. And so when kiddos turn into that adult period, it can be really hard to find providers that are not only competent, but also the ones that the patients feel comfortable and safe with. We were thinking about just this population of providers working with adolescents and young adults, and how that is a really great opportunity for you to help bridge that gap. And not even if you're an expert, but just making sure that this patient maybe has resources or connections to support groups to help bridge that gap of finding adult care. And this slide just highlights again the need to really improve adult intersex care. This is a study from 2020 that was done with UCSF, and really looking at intersex identifying adults, asking them their perceptions of their own physical and mental health. As you can see with the light blue and the yellow kind of segments, there's a big portion that are pretty unsatisfied with their health care and see it as poor. Nearly 50% with physical health and over 50% with mental health, and showing higher rates of anxiety, depression, and other mental health conditions. So this is me as a 2, 3-ish-year-old. Adam and I wanted to pause in this presentation and just share a little bit about our own personal journey living with a DSD condition. I mentioned already that I have congenital adrenal hyperplasia, or CAH. We talked a little bit about CAH, but the high-level overview is the body is unable to make cortisol or make enough cortisol, which is a hormone needed to sustain life. Because of this, people with CAH need management lifelong, primarily through endocrinology, but other potential specialties as well, including urology and others. I really wanted to take a time with my story to talk about adrenal crisis because this is, one, a passion of mine and also something that I think is really left out in this discussion of DSD and the intersex community. CAH is one of the only conditions in this umbrella group that has some really true medical concerns that can be life-threatening, one being adrenal crisis, which is basically caused by a physical stressor such as breaking your arm or having the flu and having a fever or going in for surgery. Someone without CAH would start to make more cortisol to support the body during that physical stress. But with CAH, we're not able to make it, and that can lead to potentially really serious side effects and even potentially death if not treated promptly. Because of this, it's really important to educate people with CAH and their families and the people around them the importance of having an emergency injection kit. This is basically Solu-Cortef or IM form of hydrocortisone that should be on the person 24/7 that can be given immediately if there is some type of emergency crisis like adrenal crisis. Also thinking about just my time with CAH in that adolescent time frame, I think there are a couple things that really jump out to me as being important to consider. One being, this is often a time when medication management shifts from parent control to the patient, the child, and that can be overwhelming and daunting, but also an exciting time to just be like, hey, I have ownership of this condition and I can start learning more. Another thing to think about is this may be a time when kids go off to college or they're going to camp or sleepovers, which means making sure they're bringing that emergency injection kit and also potentially educating the people around them of what to do in that type of situation.
This is me as a baby. It always cracks me up. So I was thinking about like my path to diagnosis and some of those intersections with adolescence, and I kind of wanted to talk about like 3 specific interactions. I have what's called a 46XX DSD of unknown etiology, which essentially means I do indeed have XX chromosomes. We've checked it a few times, and we did a bunch of other testing, and they don't know why exactly I have what I have, but I was born with a combination of streak gonads and ovarian tissue. So what that meant for me was that I went through like 1.5 periods and then didn't get any more periods. And eventually, when my parents kind of figured out, that's when they took me to see a doctor. I like to laugh. I think sex education is really important too, because I thought you got like 1 period and then you were officially like a woman and you had like made it and you never had to get a period again, which is why it took so long to flag the fact that I was intersex. But yeah, once they did, they took me to see a doctor. And the kind of 2 things that stuck out to me about that after I got my diagnosis, the first of which was that my doctor was like, oh, like, it's okay. I know like 1 other girl like 3 counties away who has this, right? This is the only like knowledge that I had of other people with the condition. It was like the only knowledge that I had of the fact that like maybe there would be somebody else I could meet. And I think it's why I'm like super invested in making sure that everyone gets access to support groups and the work that I do in clinic. Because I think that intersex kids, when they get diagnosed, they deserve to see people who look like them and be connected to people like them. I think that's really important, and I didn't get that. And I think about that a lot. The second thing that she did was she stuck me on estrogen and went, great, you're a woman, have a nice time, and then she retired. Yeah, great healthcare experiences. What that meant was that I started to go through a transition that didn't work for me. I didn't get any type of counseling about, right, like, hey, like you could go on testosterone or you could go on estrogen, and here are the different things that would happen, right? If you go on testosterone, you'll see things like your voice dropping, and you'll see things like facial hair and that, and if you go on estrogen, that period you had once is gonna come back. Now it's gonna be like a monthly thing, and also like breast development and things like that. right? And so I think if you are ever kind of working with intersex young people, making sure to offer them all of the options, even if you're 99% certain that that intersex young person has a certain gender identity, it does not hurt to be like, do you want to talk about testosterone? And they'll be like, no, thank you. And then you can move on. The second point I think about was when I was 18, and I remember going to get gender-affirming hormones for the first time, and I went to like Howard Brown. I won't be too shady, but I did go to Howard Brown in Chicago, and I talked to a doctor, and I remember being like, he was like, oh, like, do you have anything else that like could impact this? And I was like, oh yeah, I have this like hormonal thing. Here's what happened, and I just remember him being like, oh, like, I don't know if I can treat you. Like, here's what I'm gonna do. I'm gonna prescribe you testosterone once, and then here's a list of a bunch of different medical tests that you need to go get, and I won't prescribe you testosterone again until you get them. What that meant to me at 18, struggling to access healthcare and health insurance by myself, was that I took that testosterone and ran, right? And I did not come back until it was out. And so that type of counseling wasn't effective. I really wish that he had sat me down and been like, hey, like, here's what I know, here's what I need to know in order to provide you the best quality of care. How can I work with you to connect you to those resources, right? How can I connect you to genetic testing or endocrinology or whatever you need? Instead of just giving me a list and being like, go figure it out. And I was like, this is not gonna happen. And then the last thing that I always like to talk about with my story, because I think I'm really lucky, is around fertility. So I remember when I was 17, I had a really difficult conversation where the doctors were like, oh, like, you do not have any fertility potential at all, right? They sat me down, and I think that's the case for a lot of people who are intersex. But one of the things that happened for me was that I was able to pull my medical records, and as I was working in clinic, what I realized is that the methods that we have for fertility preservation have changed over time. And so some of the things that we've come up with that are really helpful for cancer patients and trans patients are also things that can be really helpful for our intersex patients as well. We do a lot of what's called gonadal tissue cryopreservation in clinic. And when I started to kind of put the pieces together, I remember just asking my doctor, I was like, hey, like, would it be an option for me to get like ovarian tissue cryopreservation done? Is that a way that I could possibly have like fertility potential, or at least hope for fertility potential? And I got really lucky. I have a really high level of medical literacy. I work in a clinic. I know all the doctors, or if I don't, I just drop names of doctors I know, and the doctors that I see know those doctors, right? And so they trust me. And so I was able to access ovarian tissue cryopreservation at 22, and I was able to kind of preserve that like hope for the future. And the kind of two things that like stick out for me from that, the first one, right, is like, I really would like everybody, no matter where they see a doctor, no matter where they are, to have that issue. So if you are working with an intersex patient, I think asking, hey, like, are you interested in talking about fertility at all? No matter the age, I think for some intersex patients, fertility might be something that's relevant at a younger age. For me, it was relevant at like 20 to 22, right? And then also just being able to try to connect them to those resources if possible. That's part of why I'm going into medicine, not to like drop like a shameless like side, but I'm going into medicine so I can make sure that other people with similar conditions have the same access to fertility resources as I did, so.
Thanks, Adam. So after kind of going over just general foundational understanding and some history about the intersex community, we wanted to then really talk about what does care look like, what's the standard of care these days, and what are some concrete things you all could take home with you and bring back to your clinics. We'll talk a lot about multidisciplinary care and that model of care being the standard of care, primarily for a number of reasons. One, everyone's all in one space. As you can see in our clinic, we have a number of different specialties with endocrinologists, pediatric urologists, specialized nurses. We have a great team of psychologists. One is here with us today. And this allows the patient to really make sure they're getting the highest standard of care, and just making it easier for the patients and families to see everyone in that same space. This is a picture of our clinic in Chicago. We generally all come together about twice a month and meet with patients and their families. Outside of those specific clinic days, we offer patient and family support. That could look like appointments ongoing with a psychologist, follow-up with endocrinology outside of maybe that actual DSD clinic day. We also put on a number of support group events and a community outreach presentations either within our Lurie community or the outside larger Chicago community as well. So as mentioned, we do a number of support group events, which is probably one of the favorite things about the job for me. We do, as you can see, lots of different things. Sometimes they're condition specific, sometimes they're age specific. We've even done events for parents. So they have a time to meet with each other outside of that clinic setting or outside of having to watch their kiddos. These events have been either virtual or in person. This picture you can see was one of our in-person events at a baseball game over the summer. There's no patients in this photo. It's primarily all our providers and their kiddos, but there was a number of patients and families that attended as well. A couple of things I think that's really amazing about support group events is, one, it gives an opportunity for the patients and families to interact with providers outside that clinic setting. Sometimes clinic can be stressful and it's not the best time to interact with each other. And most importantly, it provides a safe space for patients and their families to interact with people who may have similar conditions or may be going through similar things. We also do a number of educational trainings. As you can see, here are some that we commonly do. One training in development is we're hoping to educate NICU providers on competent care when they may interact with a newborn intersex baby. Awesome. And now we're going to talk a little bit more about those tangible items that we can take on.
I think the first thing, and I've been reading through the questions, and we're going to talk about sexual health later on, so I'm glad we got a lot of questions about that one. But another thing that I always like to talk about is that different members of the intersex community may have different levels of medical trauma, right? Some intersex people, a lot of the intersex people that I work with in the support group that I'm a part of have a history of feeling pathologized or traumatized in a medical context for a variety of reasons. That could be anything from they have kind of feelings about or opinions about the surgery that they received. It could be due to genital photography or genital exams as well. And that can really impact the way that somebody accesses medicine throughout their lifetime. And I always remember I was with my friends who are not intersex, they'll be like, oh, this happened. And I'll be like, okay, maybe you should go to a doctor and get that checked out. And they'll be like, yeah. And with my friends who are intersex, they're like, oh, this is going on. And I'm like, well, maybe you should go to a doctor and get that checked out. And they're like, no, I don't know necessarily if I need to do that. Or maybe I'll go see this one doctor in Boston that everybody else sees. And I think I have a really hard time kind of facilitating that connection to accessing medicine because folks are so worried about experiencing more trauma when they're accessing medicine. So things that could be really important include things like listening to that patient and allowing them to be involved in any medical decision making. I think this is especially important for intersex patients who feel like decisions were made for them when they weren't old enough to make those decisions, right? It would be really important for them to then be able to take that kind of control in making those decisions. You want to make sure that you explain what you're doing and why you're doing it. Honestly, these are if you've ever been to a session on trauma-informed medicine, I'm pretty sure these are kind of the same principles, but just making sure that that person is really aware of what's going on. I think admitting when you don't know something and doing your research is something that a lot of us look for in our doctors, right? We know that a significant amount of physicians aren't going to have like a ton of expertise in working with intersex populations, but we would like to know that you are kind of at least willing to try and at least willing to do the research to work with us to figure it out. And then apologizing if you are making a mistake, using insensitive language, or using language that someone doesn't use. I always say, right, it is okay to make mistakes, but you do want to make sure that you kind of own and recognize that people have really strong opinions about the type of language that works for them and is best for them. And if you don't use that, that might cause that person not to come back and see you again.
Awesome. So some additional tips for making a more inclusive space. We kind of already talked a lot about this, but really making sure you're using language that the person feels comfortable with. So adopting inclusive non-gender language, that could look like changing forms or long-term more maybe changing the EMR charting. Something just simple though that you could take back tomorrow is being mindful of asking what that person prefers to call their condition or what pronouns they may use. We also never want to assume about body parts, what body parts someone may have or may not have. Again, that similar theme of just asking and not assuming. And in tandem to that, oftentimes, as Adam even mentioned, intersex people have to educate a provider on their medical diagnosis, their body. This can not only be emotionally exhausting, but it also can be hurtful if someone tries to pretend that they maybe understand it. So it's really important to recognize, hey, if I don't know something, that's okay. Let's work on finding the answers and refer out if needed. And another thing we sometimes see in our clinic is that an adolescent may actually not know their diagnosis. Unfortunately, sometimes we even see like 16, 17-year-olds that have no idea about their diagnosis for various reasons. It could be maybe the family, the parents aren't ready or don't know how to share that. But being mindful of you wouldn't want to be the person to just like blurt that out and make that a very big shock for someone. So if that conversation needs to be had, making sure you have the right resources around you, specifically psychology and other family members, providers that may be helpful. Another really tangible thing that can be used to create an inclusive environment is adopting an organ inventory in your EMR system. This allows you to really highlight specifically what body parts someone may or may not have. You could also indicate if someone maybe has had surgery or not had surgery on a specific body part. And this can be important for a number of reasons. One, it could allow the patient to not have to re-explain their medical history when they're going through your organization. And it can also hopefully prevent some unneeded testing or medical treatments for certain people. Just as an example, someone with AIS, they may present as female, identify as female, but internally they have testes, which means there's not an opportunity for them to be pregnant. By doing an organ inventory and noting that, there's a chance to avoid having to ask that person, hey, is there a chance you're pregnant, or let's just do a pregnancy test, which could actually be really traumatic for that person. All right, I heard there's a lot of sexual health questions, so.
Yeah. I'm actually going to pull back to the organ inventory really quick because I think we have some time. The other thing, too, I just want to say, I don't think I've ever seen an organ inventory that looks like this specifically. You can see at the bottom, I've added a few more things. If you're kind of in the process of updating your hospital to be more trans-inclusive around this, it'd be a really good time to have a conversation about, are there things we could add to our organ inventory that would also allow us to kind of capture the experiences of people who are intersex as well? I also want to say, I don't love the term like intersex genitalia in an organ inventory. mostly because I think people use different words for that. I think if you can have an option in your epic to say other and really describe what that person's specific genitalia looks like, that's probably the most effective way to be able to do that. Okay, now let's talk about sex. And we got I'm reading through y'all's kind of what you really wanted to talk about, and I think sexual health showed up a lot. So I'm gonna take a little bit extra time on this slide to talk about it a little bit more. So you can see here, one of the things that I thought was really interesting is that I think, and I don't know the statistics for the general population, but I think intersex people are a little bit more likely to talk to a physician or other healthcare provider about their sexual health. Or to go for sexual health information. I think part of that is because the information that they get in schools is frequently not applicable or not kind of accurate to their body and body type. And so who else to talk to would be physicians, other people your age, or parents, which most people aren't doing. Some of the things that I really like to flag when it comes to sexual health for intersex populations, including that there may be difficulty using external condoms due to size. So that's one of the ones that comes up a lot, is if somebody has a small penis or an enlarged clitoris, they may want to engage in penetrative sex, but condoms only go so small and they may not be able to do so. So I always like to say we have internal condoms and we have external condoms, so there is an option for that pair, which is to use an internal condom instead. Another thing is, and it was in a recent study, a 2023 study, is they found that intersex people may be more likely to engage in receptive anal sex. And I think in general, what I've found in community spaces is that intersex people may be more likely to engage in alternative types of sex, things like oral sex, things that aren't penetrative sex specifically. Again, that's very person to person dependent. And again, I'm kind of working specifically with people who use that identity term intersex. But that would be important to know, because when I think about sexual health counseling, talking to youth about safe sex, a lot of times we don't talk about anal sex or oral sex and how to be safe. And so talking a little bit more about things like dental dams, lube, anal sex safety and things like that could be really useful and really helpful. Another thing that I have found specifically is that if somebody has kind of knowledge of infertility, that may lead to a lack of use of protective methods. Or what I frequently find is that if somebody thinks that they can't get pregnant, they think that they also don't need to use condoms. So I've seen that a few times. And so having that conversation about yes, pregnancy, but also STIs, and if you are intersex, you still have a risk for STIs depending on the type of sex that you're having. That would be really important as well. Some intersex people may still need or want birth control. That was one of the questions that I got. Essentially, if somebody has a uterus and ovaries, they will be able to get pregnant, is kind of the way that I always think about it, right? So the way that I think it through with other intersex folks is do you have a uterus? Check yes. If you also have ovaries, check yes. Then you may still get pregnant, and in that case, birth control may be a really good option for you. The other thing that kind of comes up with birth control with intersex people is they may have some differences in anatomy. So if somebody has a double uterus or somebody has a smaller uterus, anything like that, it may lead to a difficulty with things like IUD placement. And what I've been told, although I am not a doctor, but by doctors, I have a lot of friends who are pediatric gynecologists. What I was told is that there may be options to place IUDs for people, but they may need to be done under a scan, for example. So under an ultrasound, in order to kind of watch it go in and make sure that you're able to fit that in with that person's kind of unique anatomy. If a person has two uteruses, they would also need kind of birth control for both uteruses. They could get pregnant in both. So. And then the other thing that I always like to point out is just this lack of research on sexual health experiences. I'm the person who really likes to Google intersex and then a word HIV or intersex and sexual violence, and honestly there's nothing. It's really sad to go on the internet and to not be able to find any type of resources or information about the community. It's why I think there's such a need for research, right? Is we need people like you all to look at sexual health experiences and rates of HIV in our community, because right now we don't have any numbers at all. So in conclusion, and then we're going to run into some scenarios, resources, and we'll have time for questions too, because we're doing pretty good on time here. One of the first things that I always like to say is that if you are interested in being more intersex inclusive and you want to do this work, which I hope that you do, it is really important to actually provide tangible resources to intersex community members. In part, right, because intersex people are a marginalized community, we see those decreased rates of things like employment and access and things like that. But also because I see it a lot where people are like, oh, like I do want to support intersex people, so then they will like reach out to the intersex people in their community only to ask them to do something for them. I think intersex people's like time is important, and if you really actually want to do this work, like you do actually have to pay people for their expertise. Yeah, Lurie Children's Hospital like is one of the first and only children's hospitals to actually like pay and employ intersex people to work in their clinic with their patients. And I think that that is a really positive step that they did. Other things, please educate yourself. I think coming to here is a really good step. I think kind of there are sessions that go into a little bit more of that like medical nitty-gritty as well, and so kind of doing some of that education work. One of them is on here. My friend Katie Dalkey is a doctor, and she's done a session on essentially like intersex inclusive care that's a little bit more like medically focused. I've linked that if you would like to watch that as well, in order to kind of increase the amount of intersex competent providers. Please familiarize yourself with any resources you have in your area and feel free to refer. Like I said, right, like intersex individuals deserve access to support groups, they deserve access to psychological support, and if that's not something that you can offer, that's when it's really important for you to connect them to other people who can offer that. And do you want to do the last? I think you did, okay. Sweet.
And then carrying on with a big theme of this afternoon is asking the patient. We really don't want to assume anything, and that goes with assuming someone's gender, language they prefer to use, what they want to call their condition. Also, not assuming everything you see online is true. There's a lot of misconceptions as we've gone over around the intersex community. And then also thinking about fertility, don't assume that someone may or may not want to have kids and what their fertility journey may look like. All right, scenario time.
Okay, so we have some scenarios, and we're going to ask y'all to make friends with each other and turn to a friend or make a little group and kind of talk through these, and then I'll ask if anybody wants to volunteer, and we'll kind of go through our thoughts for each of them. And if these suck, please tell me afterwards, because I wrote them, so if they suck, I will rewrite new ones. But they were reviewed by doctors in our clinic. So this is the first one. Sierra, 18, has come to see you, and she wants to discuss access to birth control. You are reading their medical records and realize that they have a DSD or intersex condition that may impact their fertility potential, but you do not know if Sierra knows about her medical history. How are you going to determine her knowledge levels and interests? So if you could turn to a partner or a friend and talk about how you would determine that. Oh, yeah. To my online friends, if you can just think about it, and if you put anything in the comments section, I'm reading that, so I'll get your comments. Okay, and if you want to kind of wrap up your conversation. Any like final thoughts? And I'm going to ask people to be brave and volunteer. So if anybody wants to talk about what they talked about, um, I am going to ask for that in a second. So. Okay, does anybody want to talk about like what you talked about? Does anybody want to talk about how you would go about doing this in your clinical practice? Any volunteers? Yes. She and they. You don't know. Right. Yes, go ahead. Right. Right. You're off to a really good start. Can you click to the next slide? Yeah, so, and I made her 18 on purpose because I did want to make it more difficult than like, oh, you can pull like a parent aside and ask a question. I also think this might come up if you're working in like a Title X clinic where you're seeing a high school student. This may come up as well, although I don't know if you would have the same access to medical records there, so it might not be as much of an issue. The first thing, so I asked our physicians, the first thing they said was just to ask why she's there. I know in the prompt I said birth control, and so if she was there for birth control, then it would be important to find out. If she's there for like STIs or something like that, it might not be as important. And then just having that conversation about medical history. And one of the things that they suggested is to soften it by asking about family history first. Right? Does anybody in your family history have a diagnosis that affects fertility? Anything coming up for you? Does this sound familiar? And then if not, asking if she may know about any reasons. The other thing that I was just thinking about is like kind of being prepared for if you may be the first person to tell her. I think one of the things with folks who are intersex is that there are, like Adrian said, cases where people are finding out at 18. Or what we see too is that people will find out that they're intersex at 25, 35, 45, which I know is a little bit less relevant for all of you. But I think kind of coming up with a way to do that and to kind of know that you have the resources to be able to refer her if that's something that's really upsetting for her. Anything to add? Nice, okay. Yes. Right, which is why we're talking about this too. Yeah. No, I think y'all nailed it. Yeah, you. Oh, go ahead.
I agree. I think one thing to just keep in mind too, what we talked about, that if they don't know completely and you just kind of lay that on them, that could be really overwhelming. And if you're not prepared to have that conversation and have those resources, have that support, that could be traumatic in a way as well. But overall, yes, at the same time.
Yeah, it made me think of two things. The first of which is that like shame and stigma, and historically, like a lot of that comes from the medical practice of not telling intersex people about their bodies. I have a slide in a different presentation from like a 1960s like medical journal where they're like, oh, like this person has a gonadal variation, and we're not going to tell this person about it because it will be easier for them if they never know. And so I think we do have to have these conversations. It's that like tug and pull of like how to have it in a way that is also like sensitive. So I should just have y'all teach though. Y'all kind of like nailed that. Okay.
All right, so we have a second scenario thinking in the ER mindset. You have a patient come in, Sandra, let's say she's 17, has come in for a fever, difficulty breathing, and a cough. You notice on her chart that she has complete androgen insensitivity syndrome. What would be some important factors to consider, and how would you continue? Awesome. Well, if you could come back together, anyone want to volunteer ideas, thoughts on this scenario? And as we were talking about the last scenario, I think some of the same themes that came up also apply in this scenario as well. So, yes, like a broken arm syndrome kind of thing. Yes, yeah, exactly. Oh, I went backwards. Exactly. Yeah. So we, again, thinking about like we should just treat this patient exactly as anyone else with the standards of care if that intersex variation doesn't apply to the situation. This person came in for a fever, a cough, and really their intersex variation has nothing to do with those symptoms. I will note, we've talked about CAH. That might be completely different scenario. We talked about adrenal crisis. If they have a fever, they most likely will need to get hydrocortisone immediately as soon as possible. Awesome. All right, a couple more, and then we'll just have a little bit more time for questions.
Okay. So here's the next one. Sean, 16, has come to see you because he has a rash on his genitals. You have let him know that you need to perform a genital exam, and he immediately stiffens up. He says if you have to do a genital exam, he's just going to leave and asks if there's any other way that you can treat him. We are assuming that Sean does have an intersex condition or a difference of sex development. What might be going on here, and how could you proceed in this scenario? Okay, let's talk about this one a little bit. What did folks talk about? What might be going on here? And then did you talk about any kind of like strategies to proceed? Yes, go ahead. I love that. Did anybody talk about anything else? Is that kind of the main? Yeah, so what we're seeing here, right, is that Sean may have had previous negative experiences with genital exams. I was kind of thinking, like, I didn't know, right? Like, is there a way that you could kind of do this without having to do the genital exam? It sounds like there are a lot of options, right? Or a few at least, like asking for a picture, asking to only show like a part of the body. Other tips that I had or I was thinking about, one of them is just to have a conversation about like, what exactly are you doing? Why exactly are you doing it? What exactly is it gonna look like? You're gonna wanna play Sean through like the whole thing beforehand so that he can kind of consent in an informed way to that. Other things are just like offering ways to make it more comfortable for him. That could include asking him like what ways, but also offering some suggestions. I think especially with an adolescent in this age bracket, he might not know like what types of resources would be really helpful to him for this, and so offering those and having that conversation. That could include things like him deciding who's in the room. Like I said, like in some places, like historically, there has been like a history of like genital exams for intersex people where they kind of like parade every resident, fellow, and student past you because you're like the only one we're gonna get in the hospital this year, so like everybody better go learn, right? And if that's kind of the experience that Sean has, having a bunch of extra people in the room or even having one student in the room might not be a good option for him. That also includes, right, like deciding on the genders of the people who are in the room as well. You're really going to want to be clear about what you're doing and describing it as you're doing it. No surprises or jumps or anything like that. If there's a way to allow Sean to do part of the exam, I love that example of just like pulling down like slightly, right? That way Sean is kind of involved in that process. You could offer for Sean to have a support person, right? Does he want to come back with a parent or a friend or the one aunt or uncle that he talks to about all this, right? Like who's that person and can he come back with that person to have some support in the room? And then the last thing I was thinking of as like a last resort is like, if you don't have a ton of rapport with Sean and he's really saying no, you might want to set up like a follow-up appointment, right? Maybe Sean will not do it in this appointment, but if you can just develop a relationship with him, he might be a little bit more comfortable doing it at an appointment later that week, and then he'll kind of know that it's coming and he'll need to have that. So those were the things that I was thinking of in addition to like Yale's ideas were great as well.
All right, one more, I think, maybe one or two, but a little different direction. So you're talking with your colleague who is a therapist who just recently spoke with one of her adolescent patients who has congenital adrenal hyperplasia. The therapist offered a number of intersex resources, intersex support groups to the patient, and the patient immediately looked offended and turned them down. What would you maybe do next, and how could you prevent this in the future? All right, just coming back together, any thoughts, ideas that you all came up with? Yes. Yeah, yeah, yeah. Yeah, good point. There wasn't the actual. That was actually right on point. So, basically, the with this scenario is the patient really just does not identify with the term intersex or being intersex, even though there could potentially be variations of sex development in the CAH population. A large majority of the CAH population really doesn't actually feel comfortable with that term or identify it, myself included. And so what we could do to kind of make this situation a little bit better is to really ask them what terms they prefer to use. Do they want to just say CAH or other things? And then depending on the relationship with the patient, it's always important, no matter what the relationship is, it's always important to apologize and say, hey, I'm sorry I made this mistake. You could offer CAH-specific support groups and resources. And if needed, there's always the potential to offer a different provider. Yeah. Very good point. Yeah. Yeah. Yeah, and going back to like the physical broken arm syndrome, same with mental health. You don't want to assume they're coming to you because of their variation or their intersex trait. So, just in the interest of time, we're going to skip the last scenario and just briefly talk about resources and then have a little extra time for questions. So these are some really great support groups that we love. It's broken out into general support groups. There are a lot of variation-specific support groups and specifically advocacy groups like Interact. Just to note, all of these support groups often have adolescent or young adult specific groups or communities they can join as well.
These are some of the books that we recommend. Just going back to the support groups, it popped in my head like Discord. A lot of these groups are starting to like come up with like different forms of technology besides Facebook that are working with like adolescent populations. Like Interconnect, we have a Discord group, which is where a lot of our like younger members go. These are some of the books that we recommend. I know you're probably not working with littles, but if you do have like a younger relative, a niece, a nephew, something like that, Neither is really cute by Arlie Anderson. With that age bracket specifically, when we're talking about like books about intersex topics, what we're really talking about is books that normalize differences. Cattywampus is for like either like it's like a middle school age bracket probably, but also if you have somebody who maybe doesn't want to read like a longer book, that one has a character in it who has androgen insensitivity syndrome, and then none of the above is what we usually give out and recommend for our high school students. And that's when it's like a little bit more of like a cut and dry, like this person finds out they're intersex and kind of gets support for it type book. And we're leaving some time for questions as well, but I did want to put up our resource list. You can access it here via the bit.ly or via the QR code. So, but we will start taking questions. You're welcome to ask them, or we did get a number of questions in the app, and if you want to ask them in the app, we'll go through those as well, especially for my friends online. So, Nice. Okay, and I'm going to start going through them. I think we talked a lot about how medical practitioners can support intersex use, so we're going to skip that one. There's a question about PCOS, or polycystic ovarian syndrome. We actually got 2 of those, and whether or not that should be considered a form of intersex. Again, this is something where it definitely depends on like who you talk to and how they choose to define intersex. So I think in my conversations with the medical community, I would say they do not consider PCOS to be an intersex variation. In my conversations in community spaces, I'm starting to see more and more people do that, especially for people with PCOS who have visibly different secondary sex characteristics, things like facial hair and things like that. But it really depends like person to person. Oh, yes. Go ahead. I don't. No? Okay. We do not. So I have some resources around like how to talk about like puberty and sexual health, but I don't go into like the hygiene at all. So that would be something that might need to be created. Yeah, go ahead. The way that I'll answer that is around some conversations that I've been having with research folks about kind of how to do this research. One of the things that we've started to talk about is the way that that word intersex is not resonating with everybody. And so I don't know if I necessarily would do research specific to each community, but what I would do is I would tailor my research and the language I'm using to that community. So if I'm trying to do research about sexual health and I want to involve like beautiful you in the MRKH community, and I also want to involve like the CAH community, like the language that I use when I reach out to MRKH would look really different, but the research would kind of come together, I guess. That would be my strategy. Yes.
That's a really good question. I think my initial thought is any care is better than nothing. So if resources are lacking or in more rural communities, whatever you can offer, the best. But keeping in mind if there are specialties or resources that aren't available, making sure to offer that to those patients and making it available if psychology is not prevalent in the area or urology, and making sure they're seeing people that really specialize in those needs. Uh, maybe Adam can add on. I thank you. That's great. I think the one thing to maybe be mindful of is if it's described or labeled as like this kind of clinic, and people who don't identify with certain aspects of that are coming and they're like, wait, what is this for? Then you might run into some things, but.
Yeah, I would kind of say like being really clear that you're kind of doing two things at the same time. I think that access to resources is important and most people would understand. The kind of like thought in the back of my mind is I think that for parents of like intersex like newborns specifically, there's a lot of worry around like gender, and that's the only thing or it's not the only thing, but it's like the first thing that came to mind that might be a concern is like, oh, like if I'm bringing my young person to this clinic, does that mean that they're definitely going to end up as trans? And so having kind of language about like, hey, like this is the trans clinic and the intersex clinic, and those are two really separate populations, but here's where the endocrinologist and the psychologists are in the same place at the same time is what I would do. Yeah. Yeah. Yes, and there is medical controversy around that. So I kind of like, when I talk about surgeries, like I kind of have to talk about some different perspectives. So there's like the perspective of what we call like the 2006 statement of intersex care. That statement kind of includes surgery as an option. There's a perspective of some clinics, including ours, where we are kind of banning certain surgeries. For us specifically, it is non-medically necessary, irreversible surgeries. That's language that kind of Lurie Children's Hospital uses. And then there's kind of the perspective that I see among certain intersex community members, which is a little bit more around like banning surgeries. And I think that that's what I would be aware of, is that you're going to run into those different perspectives. And so to kind of prepare for that. If you follow up, that's my email. If you follow up with me, I can kind of help continue that conversation. So, and we did, going off of that, and we are at time, so I'll just do this really quickly. We got one more question, which was just around like policy and language. And one of the things that they pointed out is that I don't know if the Society of Adolescent Health and Medicine has policy or language around this, but that might be something to look into as well. So that's all. Thank you.